everybody, and welcome. My name is Bill Harder. I am the Palliative and Grief Support Navigator for the Palliative Care Society of the Bow Valley, and we are located in Banff and Canmore in the Rocky Mountains, for those of you that are from far away. So this morning and the first part of the afternoon, we have a fantastic opportunity to engage in conversation. And before we do that, I would like to just guide us through a couple of pieces. And the first is a land/treaty acknowledgement of the lands that those of us who are in North America, at least, are situated upon. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the lands which we call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and cultures. From coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, the Métis, and the First Nations people that call this land home. In the last year, our Indigenous brothers and sisters have been navigating the painful discovery of the remains of children across our country connected to the shameful history of Indian residential schools. As we gather today in the spirit of truth and reconciliation, we can honor the lives of those lost children by committing to our own personal learning and unlearning journeys. As we today gather, we can commit to connecting to and learning the true history that brought us all to where we are. Now, I'd also like to do something very important, which is to acknowledge and give thanks to those who have sponsored today's event. And that includes locally the Bow Valley Builders and Developers Association, the Banff Canmore Community Foundation, and the Diane and Francois Poirier Foundation. And for all of these people who believe in the work of palliative end-of-life and grief care and in education around these themes, thank you for making this possible. So without further adu, I would like to introduce you to our keynote speaker for today. And then when we have the gift of conversation with her, we'll move into our panel and I'll introduce our panelists at that point. Dr. Kathryn Mannix is an author, speaker, and death literacy advocate. What a delicious term to flow off the tongue, from the United Kingdom. She believes that every individual can optimize their quality of life, even with a lifelong illness. Dr. Mannix has dedicated her 30-year career to palliative medicine. In 1993, she founded the first cognitive behavioral therapy clinic in the UK, exclusively for palliative care patients. And from this CBT clinic, she established CBT First Aid training to enable palliative care colleagues to add new skills to help her patients. Dr. Mannix is a renowned author and has published 2 books, With the End in Mind and Listen, and both are available in North America. Without further ado, I invite Dr. Mannix to share her thoughts around our personal annual theme, which is Imagine. And for today, it is Imagine Ordinary Dying. Dr. Mannix.
Hello, everybody. I can't tell you what a pleasure it is to be with you. I only wish we could do this actually all together in a room, but it's lovely to be able to join you in this virtual way as well. I'm going to talk for half an hour or so, possibly a bit less than that just now. And then we're going to get together with my collaborators and friends, Brian and Dr. Hsien, and just mull things over and invite you to have a conversation with us. So first of all, I'm going to press the buttons to make some slides appear. Let's hope that that will all happen smoothly, so I look like I know what I'm doing. Those are the slides. Hooray. I thought I'd just start by giving you a flavour of whereabouts in England I live, in the very far north, almost in Scotland. And this is the remains of a really beautiful priory, which was later fortified on the northeast coast of England in a place called Tynemouth, which is the mouth of the River Tyne. So welcome to my little corner of the world, and greetings across to yours. Now then, let us begin. And I'm going to begin, I guess, with a bit of a palliative care joke, because I'm talking about euphemisms, and I guess curtains is one of those. I'd like to invite you to imagine how knowing more about the process of ordinary dying might really change the way we live, the way we think about dying, and the way we face the end of our lives. Really, mainly, I'm going to show you my holiday photographs. So just relax and let's have a look at this beautiful, beautiful tree. It's a single tree. It's called the Angel Oak, and it's on the outskirts of Charleston in South Carolina, where some friends of mine live. Nobody really knows how old this tree is. It may be somewhere between 500 and 2,000 years old. It looks as though it's immortal. Here it is, having spring, possibly for the 2000th time. And later in the year, the tiny little flowers on this tree, we don't often think about flowers on oak trees, do we? But there are tiny flowers, and they'll become acorns. And they are the insurance policy for this tree, because it will sow seeds into the future, because it's going to die. And you're going to die, and I'm going to die, and all the people we love are going to die. And the people we don't like very much, they're going to die too, if that's any consolation at all, because that is the natural order of things. But we very rarely look death in the face. We very rarely make inquiries about what's likely to happen. And it turns out that that's becoming a bit of a problem for us, because we've lost sight of what ordinary dying is about. And we've lost the language of it even. We've started to talk in euphemisms. We don't use the D words like dying and dead and death. We've started to talk about passing and passed away. Now, for some people, that has a religious or a spiritual significance. But for many people, it's just a way of dancing around, saying some scary words. I want you to think about how well protected your body is to keep us alive, that we are able to do things involuntarily by reflexes that protect us. So if we touch something hot, we'll move our hand away even before we've really realized that it's hurting us. If we get a toast crumb or a bit of coffee at the back of our throat, we'll cough and splutter to protect our airway. It's one of the most sensitive parts of our body. If we get a fright, we'll make a rush of adrenaline, and that's protected us in the past from saber-toothed tigers and might now get us across the road in time to avoid being hit by a motor vehicle. So we are hardwired to survive. Those are the physical survival reflexes, but we've got emotional survival reflexes as well. We are absolutely masterly in swerving around things that are going to make us feel uncomfortable. So if we were in a room right now, I'd ask for a show of hands for the number of people in the room who don't like spiders, who really, really don't like them. And I promise all of you, there are not going to be any pictures of those creatures, and I'll try not to say the word too often, because people who don't like them really, really don't like them. They're so afraid of the idea of a spider that they will go to extraordinary lengths not to encounter one, not to have to think about them, and not even to have to think about thinking about them. So these people are never going to go and find the barbecue in the garden shed because they know what else is in there. These people are never going to come on camping holidays with us out in the wilds because they understand what's lurking there. They build their lives to protect themselves from facing their fear. These psychological swerves that we make that prevent us from having to even thinking about a thing that we fear. And we've started to do that about dying and death, giving away the language, not actually seeing it happen for real, and yet supposing that we know. So the euphemisms we use, like sunsets like the transformation of caterpillars into butterflies, like turning leaves, all different ways of thinking about an important part of our life cycle without actually thinking that death is involved in that part of the life cycle. So how did we get to here? What's happened? Well, I want to start by telling you a story. I want to tell you the story of Annie, and I'm going to illustrate the story with not a photograph this time, but with a graph. What this graph shows us is life expectancies of babies when they were born by the year of their birth. And these are the data for England and Wales, which are collected in a single cohort by our Office of National Statistics. A separate couple of lines that are almost as long, which are for Scotland. And then I've collected the Canadian data as far back as I could find it. So what you'll see is that over the first half of the 20th century, life expectancies for babies was starting to rise. So you can see back in the 1800s, life expectancy at birth for female infants, they weren't expected to live beyond their mid-40s. And for male infants, even shorter, because female babies are more robust. So those are the England and Wales data, and then yellow line babies, girl babies, and blue line boy babies in Scotland. And we can see how during the first half of the 20th century, life expectancy began to rise. And that's largely because we got better at stopping children from dying of things that they used to die of in infancy. Better sanitation, less likely to get sick, more likely to be born in a healthy, non-infected environment, and the beginning of immunization programs that protected children from infectious diseases. So when I've started to collect the Canadian data, here are your female infants, and here are your male infants, and this is a whole population sample. And we know that in Canada, as in the United Kingdom, there are individual disadvantaged populations whose life expectancies are foreshortened by those disadvantages. But you can see that we're running roughly parallel to each other. And in fact, if anything, women or girl babies born in the 1960s to the 2010s in Canada have a life expectancy that's a little bit longer than their cousins, sisters in the United Kingdom. The second half of the 20th century is another growth in life expectancy, this time because we got better at doing things to save people's lives. We invented antibiotics and we got better and better at them. We got better anesthetics, largely driven by combat medicine, so that surgeons could take longer because anesthetics were safer, and so surgeons could achieve more. We got better radiotherapy, we got more refined chemotherapy, we began to be able to support failing organs with machines, we began to be able to transplant failed organs and replace them with new ones. How amazing. So what's happened is a real cause for celebration. The white line in the middle of this graph represents 1948. And for us on this side of the Atlantic, that's the beginning of the National Health Service. So let me tell you about Annie. Annie was born in 1900 into a not very wealthy family in Liverpool. So her life expectancy at birth was probably something like 46, 47 years of age. During her teens and 20s and early 30s, in the 19-teens and 1920s and 1930s, Annie had the same experience that women of her age had had for probably hundreds of years. She was an older daughter in quite a big sib ship, so she would have helped to look after people who were so sick they were thought to be dying. And they would stay at home, they would be looked after by their families. If they could afford a doctor might visit occasionally. But generally, the wisdom of the community was used to look after these people. They recognized the process of dying. They knew when to send for a minister or a priest or a rabbi. They knew when to send for the relative who lived long enough away that they'd need a couple of days to make their arrangements and get there. They understood the process. There was a wisdom there. In the late 1930s, the Second World War broke out. By then, Annie was a widow. Her husband had died of sepsis after appendicitis, and their oldest child had died at the age of 7 of diphtheria because he wasn't immunized. So Annie was left a widow in the mid-1930s with a baby on the way and 3 other children. And she went into the Second World War and was evacuated with her children from Liverpool because of the heavy bombing. I'm telling you about Annie for 2 reasons. The first reason is she illustrates something really interesting about what happened over the 20th century. But the other is that she is my mum's mum. She's my nana. So Annie's life expectancy at birth was maybe 46, 47 years. She outlived her life expectancy quite significantly. When I was made a consultant in palliative medicine in 1995, I had a conversation with my nana, who by then was 95, and she was a little bit concerned about her children because once a mother, always a mother. What I'm worried about, she told me, is that when I'm dying, because, you know, I'm so old now that I will die eventually, I don't know how my children are going to be, because I don't think they've ever seen anybody die. And that was a real bombshell moment for me, because it made me realize that in the space of a single generation, the people of Britain had forgotten what dying looked like. The wisdom had been lost. My mum's generation, the people on your side of the Atlantic in their 80s, are the first generation who are unfamiliar with dying. But we don't know that we don't know, and we fill in the gaps. We find references and we paint ourselves pictures of what ordinary dying might look like. So we have a number of soap operas that, as their ratings figures drop, they add deaths to bring the ratings back up. And the deaths get progressively more gory, more entertaining, more unenlightening. And it's not just our side of the Atlantic, is it? Because I know that you have equivalent things over there. So people take their references for dying from entertainment, or they like to be entertained by weird and wonderful aspects of dying, like zombies. Or we have newspaper headlines that tell us about the exceptional, the gory, the bizarre. Just think, if you only knew about air travel, what you read in the newspapers, saw on the news, or perhaps saw in the cinema or on television, would you ever get on a plane? I don't think I would, because the plane would be full of loose snakes. Everybody would be drunk, including the pilot, or the plane would be highly likely to plunge out of the sky. The difficulty is that the media represent what is unusual, and that is the public fare now about dying and death. At the same time as that, of course, we do have this particular myth that's difficult for us all to deal with, which is the myth that CPR stops death. CPR is an absolutely important treatment. Cardiopulmonary resuscitation, by pressing on the chest like these hands are doing, squeezes the chest hard enough for blood with oxygen in it from the lungs to be squeezed through the heart and around the body to protect the brain and the kidneys in particular, which have a very low tolerance for loss of oxygen. And that is first aid for when somebody's body was working reasonably well and suddenly their heart stopped, first of all. That is not the same thing as ordinary dying, where gradually all the processes shut down until eventually breathing stops. And a few minutes after that, the heart will stop last. Cardiopulmonary resuscitation is not going to be a treatment for that. But the public don't understand the difference. And it's very, very difficult because, of course, in soap operas, people have CPR at the beginning of the episode, and by the end of the episode, they're sitting up chatting to their families. The wisdom hasn't been lost all over the world, though. In middle and low-income countries, death is still familiar. This is a photograph from a market town in the Andes in Ecuador. And as you can see, it's a funeral shop, and there are coffins of all sizes on full display, including, can you see the tiny baby coffin up at the top? This is not a place that's pretending death doesn't happen. And in fact, not only is it not pretending, I had to wait a few minutes to take this photograph because there was a queue lining up past it to get to the very popular cafe that you can see next door. Dying is in the midst of life for the people of Ecuador. People are more likely to die at home, and the wisdom has not been lost. People understand what's happening, and they know how to plan, they know how to accompany, and they're not afraid to look at coffins as they're walking up for their morning coffee. So what I wanted to do, and the reason I'm delighted to be here to talk to you today, was to really open a window onto ordinary dying, to think about how my Nana knew about dying, and she knew about it from being there, from being involved, for caring for and caring about the person who was sick enough to die, knowing that sometimes people who are obviously sick enough to die do sometimes unexpectedly recover, but very often they don't, and understanding the process. And so I started to describe what I saw, telling the stories of those people. And one of those stories is the story of a lady called Sabine. The story of the lady called Sabine is in my first book, With the End in Mind. And it's a story about her, and it's a story about me reclaiming that lost wisdom. Sabine had been a member of the French resistance during the Second World War. She must have been a very, very courageous woman. She'd married a British airman who'd parachuted in behind enemy lines to help her French resistance cell to make radio sets, and they'd fallen in love. So it was a wartime romance, and she came back to live in England with him afterwards, and they were married, lived very happily for the next 40 years. Her husband died of a heart attack about 10 years before I met Sabine. And I met Sabine when I was a newly appointed hospice doctor, having worked, first of all, in medical specialties and cancer specialties, because my original career plan had been a plan to work in cancer care. So I'd seen many people dying of the diseases that we actually have much better chances of controlling or even curing these days as a junior doctor. And I realized that actually I was much, much more interested in the quality of life and the embracing of living of people who were not going to be cured than I was interested in finding the cure for cancer. So I did a sidestep when a hospice was built in my town, really walking distance from my home. And there I met Sabine, mysterious and aloof and really, really special. One day, while she was having her hair done in the bathroom after having been showered by one of the nurses, she was talking to the nurse. And I think there's something about talking to each other through a mirror that somehow made this conversation possible. Sabine confessed to the nurse that she was very, very frightened of dying in overwhelming pain. Instead of saying, "You don't need to worry about that, Sabine, we've got great painkillers these days," the nurse very wisely said, "Tell me more about that, Sabine. What's the worry on your mind?" And Sabine explained that if she should be overwhelmed by pain on her deathbed, she might despair. And if she were to despair, then in her French Catholic spiritual framework, that would be a mortal sin that would prevent her from going to heaven. And heaven, she was absolutely sure, was where her husband was waiting for her. This wasn't just a fear of pain. This was a serious existential terror. And having helped Sabine to dress, the nurse helped her back to bed and then came down the corridor to tell our boss, the consultant in charge of the hospice. And he said to me, "You come with me. This is going to be an interesting conversation for you to observe." So I went along and I sat with them as he had this conversation. Now, a little bit of background. Our consultant had a French family, and in fact, his own father had been a French resistance hero. And most evenings before he went home, he would stop and have a little chat in French with Sabine because he was fluently bilingual, which is very unusual in the UK. She would sparkle and twinkle at him, and there would be a lot of this Gallic shrugging going on. And we would observe that she probably was flirting with this handsome young doctor, and we, the nurses and I, we would be immensely tickled by that. So he knew her very well, and he went along and he asked her where we should sit, and she looked at him and she patted the bed beside her, and he sat down there. The nurse sat at the chair at the head of the bed, and I sat on one of those little low stools at the foot of the bed, so I could see her face very clearly, and I could see my boss just beside me. Well, Sabine, he said, I hear that you've been worrying about dying in overwhelming pain. And I thought, I'm not sure you can start a conversation like that. That's terrible. But in fact, of course, he knew her very well. And she sat up and she smiled and she said, oui. And he said, I wonder if it would help you if I described to you what usually happens as people are dying. And now I was really shocked. How could you possibly do that? How could you describe what usually happens? Everybody knows that everybody's death is different. I've seen hundreds of deaths. I know this. And she said, yes. Well, she said, oui, because she was French. And he said, well, first of all, tell me whether you've ever seen somebody die. And she explained about watching somebody dying of gunshot wounds during the war, and also her husband gradually fading into unconsciousness after saying all of the prayers with the priest a few hours after his fatal heart attack. So, said my boss, you've seen an unusual death, gunshot wounds, and you've seen a normal death, gradual fading. Can I tell you a little bit more about that? And she agreed. And he said, the thing is, Sabine, that it doesn't seem to matter what people are dying from. At the very end of their lives, it's always very similar. There's a pattern that we notice and that we can follow. And the pattern is about people running out of energy. They're more tired. They need more sleep. They sleep a while and it recharges their batteries. When they waken again, they can do something that they enjoy, have a conversation, maybe walk across the room. That might be so tiring, they need another sleep before they do the next thing. You might even be noticing that already. And she said she was. And he said, oh, that's good. And by now, I'm trying to find a hole in the floor or maybe roll under the bed with embarrassment and just not knowing where to look. How can you possibly say that's good when somebody says she thinks she's noticing the beginnings of dying? That's good, he said, because that tells us you're already following the normal process. So I can describe to you what usually happens next, if you like. And if you want me to stop at any point, you just say, and I will. And she agreed. And he explained that as time goes by, what we notice is that people are awake less and asleep more, until eventually there's a time when they seem to be asleep almost all of the time and very rarely awake. Now, during that time, something interesting happens, he says. They don't notice it, but we do. Maybe there's a visitor or it's medicine time. We try to waken the person for their medicines. We don't want them to be woken because the medicine has worn off and they become uncomfortable. And we find we can't waken them. They're not just asleep, they're unconscious. Do you want me to say that in French? She said, no, unconscious, coma, I understand, oui. So he said at that point in the illness, we know we need to find a different way of making sure that the symptoms of their illness don't come back. And we'll do that for you. If by then you're needing regular painkillers, which you haven't been needing so far, then we will make sure that the usual dose is given to you that takes your pain away so that pain does not disturb you. Probably using a little injection under your skin. As time goes by, people become unconscious all of the time. By now, Sabine is sitting up. Her eyes are locked on his eyes, and she's holding his hands and stroking them and nodding as he speaks. She is finding this fascinating. She is finding this comforting. And my mind is absolutely boggling. Because what he's describing is something that I recognize. Even though I'd thought that every death is different, I recognize this overarching pattern. Eventually, he said, the only part of the brain that's still working in deep unconsciousness is the part that drives the breathing. And now what we see is reflex patterns of breathing, automatic patterns of breathing, moving from deep breathing to shallow breathing, moving from faster breathing towards slower breathing, going round in cycles. So perhaps your nieces and nephews might visit and you'll be in that phase of shallow but quite fast breathing. If they've never seen that before, they might worry that you look as though you're breathless and panting, and we'll check. But almost always, this is just a normal breathing pattern of somebody deeply and safely unconscious. And sometimes in the cycle, the breathing is slow and deep, using lots of muscles, maybe even shuddering a little bit, but it's another sign of deep, deep unconsciousness. Even that part of our throat that's so sensitive that we normally cough or splutter if anything touches it, even that isn't perceived by the brain anymore. So maybe there's a little bit of saliva or the fluid that we use for keeping people's mouths clean and moist, pooling at the back of the throat. It doesn't interfere with the breathing goes on, the air moves in and out of the airway, but if it needs to bubble through that little film of liquid, then it makes a bubbling, clicking sort of noise. We call that the death rattle. And some people are afraid of it, but actually it tells us that the person no longer feels the back of their throat. Their brain is deeply unconscious. It's far, far away from the physical sensations in their body. They are completely safe as they're dying. And then during one of those phases when the breathing is shallow and slow, there will be a breath out that just isn't followed by another breath in. It's as simple and as peaceful as that. There's no sudden rush of pain at the end, no feeling of fading away. It's just very, very gentle. And Sabine leant back against her pillows. She closed her eyes. She picked up his hands and she shook them and she kissed them. And then she told us that we were dismissed now. And as we walked away, I could feel that my mind was on fire. We can describe a process of dying that I had seen hundreds of times, but never noticed because I was always so busy worrying about one person's oxygen levels, another person's temperature, somebody else's kidney function, somebody else's hemoglobin levels. I was the junior doctor whose job was to stop people from dying. So I'd never stood back to see the overarching picture, which as he described it, I completely recognized. And that describing it to her had been the most consoling thing that he could say. That was a mind-changing, career-defining moment for me. And the stories that I've told in With the End in Mind are simply to give people the experience of understanding dying by being at those bedsides with me, so that people can begin to see that dying is as natural at the end of life as sunset is at the end of the day. Not as a euphemism, but as a thing to be understood and prepared for, because if we know what to expect for ourselves or for a person that we love who's reaching the end of their lives, we can start to think, how do I want it to be? Where do I want it to be? How do I make sure that the symptoms that might disturb my dying, caused not by the dying, but by the condition I'm dying from, how do I make sure that those symptoms are really well managed, as they were going to be for Sabine? And we do that by making sure that good symptom management has been a companion of ours all the way through the illness. It is never too early to ask for experts in palliative care to come alongside a cancer team, a liver disease team, a respiratory disease team, to work with us on managing our symptoms, even if the palliative care services come in and out of our care over a number of months or even years. The earlier we take control of the decisions that are being made about us, the better our end-of-life care is likely to run. So I'm delighted to be able to tell stories in honor of my Nana, Annie, in a way that I hope will make people want to know more. And it did. I'd only intended ever to write this book, but the correspondence from this book has all been about How do we talk to each other about this? How do we have the conversations that matter about those important things? And so I'm really sorry, I feel I should apologize that a second book has been produced. And I hope that in the same style of just ordinary stories about people having conversations that really matter, not just end-of-life conversations now, but across the lifespan, it will give people ideas of the ways that they too can get alongside people to be able to have those really important and tender conversations. So thank you for joining us today. I'd like to finish by just asking you to take a moment to reflect on who knows your wishes for how you'd like to be cared for at the end of your life. Who is your village? Because it takes a village not just to raise a child, but to support a person as they gradually do their dying process that leads them out of this life again. Who's your village? Who knows what you want? And if they don't know, when will you tell them? Whose village are you in? Whose wishes do you need to know? Who needs to know that ordinary dying is not like in the newspapers? It's not like on Hollywood, and that you now have the power to go and tell somebody what to expect. Thanks for joining us, and I'm coming back now to join the panel discussion with everybody else.
Kathryn, thank you immensely for the gift of that introduction to conversation. So we're going to just take a moment to move into a conversation, a living room conversation. I'm not sure whose living room we're in, but it is a living room conversation. And we're going to take a look at three pieces, and they are three panelists. One is Dr. Mannix. The other is Dr. Hsien Seow, PhD, who's going to provide a lens to look at the growing edge of palliative end-of-life care, what's new, what's changing, what's becoming. And as we've just heard, Dr. Mannix's work is a doorway to that real-life experience of being in the work of ordinary dying. And we're going to add to this mix our friend Brian Callaghan, who is local to our area in the Bow Valley. He is a part of the roots of our palliative care organization here. And he's going to share the lived story from the patient family viewpoint. So I want to open up this actually by inviting Hsien Seow to share his perspectives. We're going to move into Brian's story. And then we're going to bring Dr. Mannix in to really stir up this whole mix. And so let's move just immediately into you, Hsien.
Hi, Bill. Thank you so much. It's an honor to be here and see you all virtually. I have a few slides, and I'm a little. Oh, I have to. If it's okay, thank you so much. I guess apologize because you know, Dr. Kathryn Mannix is a masterful storyteller. So I'm going to try my best to tell a story, but I have many more slides, but a story of my own, I guess. And mine is about imagining a different future for patients and families and what that story is like. And the story of this project, the Waiting Revolution. But my story starts when I was 10 with my mother, who's pictured there. Her name is Swatine, which in Chinese means like snow pearl. And she died of breast cancer. She had it for, I don't know, 3-4 years. And through that journey, as a young child with my family, I think we really didn't know what to expect along the way. And even though, you know, near the end, she was really dying, no one would talk about dying. As Dr. Mannix talked about, we never really, no one talked about what palliative care is, what it could offer. Even if we might have been sort of getting it, we really did not, we were in the dark, I would say. And so we really didn't have the opportunity to understand the context making of the time. So I guess maybe while we always understood maybe she could die from breast cancer, we didn't really know it was happening. And that robbed us of the opportunity to find closure and to prepare and to say the things that we wanted to say. And so a lot of my comments are to add to the discussion, but also in the context of your community and what you're trying to build. And perhaps there's some parallels between my journey and maybe what you're trying to build. So that led me to a journey of research. And I like to talk about research as sort of a dream. So I started my journey as a dream for patients and families to get more access to palliative care, to be able to talk about it openly, and to get that earlier. For me, that the word never came up. Other people, on average, it's 18 days before death that they get some kind of palliative care, even in Canada. So that's what my career has been. I'm happy to take questions about some of the research I've done, research in home care, in primary care, in policy, in quality indicators, etc. But somewhere along the way in my, career so far, there was this feeling that we were not moving the needle fast enough. That story of people saying, I didn't hear about palliative care. I got it too late. No one ever talked about it. I was hearing in my research, even 30 years later. And so the story wasn't changing. Technology was changing. Treatments were changing. But the story of the experience wasn't changing. And so how do we go upstream? How do we really introduce these concepts? That's the problem or the issue that I sort of tackle in my research. And, maybe about 5-6 years ago, I was really sort of, at the wall saying, we have to do something different, or we're just going to end up with the same. And the light bulb moment came when my colleague, Dr. Samantha Winemaker, who's a palliative care physician, like Dr. Mannix, but she works in people's homes. We have been talking about our clinician education programs and trying to do innovative things there. But we realized the buzzword of the last 2 years, we had to pivot. We had to pivot from only thinking that the solution will come from educating providers or policy, but also what do patients and families, what is their role? What can they do? What information can we provide them so that they can be more active and empowered? So that really, when I thought about it, it was a reframe of the problem that I was trying to solve. The dream for patients and families was to change their experience. For those facing a serious illness or any sort of life-changing diagnosis, what I really wanted to do was for them to have a better experience. And so as I thought about that, it led to, in the last 5-6 years, a very different way of working and thinking. And so I'll just tell you about that briefly. We thought we could, Dr. Winemaker and I thought, okay, let's take all the tools we have at end of life, let's, make them patient friendly and put them out there. But that didn't work. That was not alone enough because people don't want to talk about death and dying so openly. I think it's something still scary for them. I think we're missing something when we go upstream, really upstream, like at the beginning of a diagnosis. And we know now even incurable diseases, there's a 5-year, 10-year, 3-year lifespan. So that's not active dying, but we are dying. You will die from this disease, but there's a lot of time left. So anyway, so just pushing the tools that we have at end of life and the science there and upstream, that wasn't going to work. We knew there was something about the experience of what people wanted. They wanted to share their stories, the advice they had, what I wish they had known. But when we looked at and we listened and collected and curated those stories, they did have a very, some of those stories were sort of traumatizing. They were not all positive. In fact, a lot of them were graphic. So there was something about the experience there that we had to harness, but not just telling stories. And we had to really think about what were the roadblocks that were leading people down this in the dark journey over and over again. So we thought about what we could do, what actions we could take. We tested different ideas. And what we realized at the end is people wanted a roadmap for what to expect. Kind of like the story of Sabine, like what to expect at dying. But I think they also wanted a roadmap of what the entire journey would be, not just in the final chapter. So as we unpacked this, and in some ways, what we really did was deconstruct what was good palliative care from all these stories, reverse engineer. And we came up with, there were these skills that people who had a better experience earlier on. And I'll just share with them very briefly here. One of those skills is this idea of walking two roads, that they were hoping for the best, but planning for the rest. They were not only, wanting to just walk the road of hope and, fighting and battling, which is what we see in TV shows, but also able to toggle back and forth as appropriate of what if this doesn't work? What if I'm not able to walk up the stairs anymore? What does that look like? What plans do we need to do so that they could prepare? In order to do that, they needed to be able to zoom out from their illness. They couldn't just zoom in the weeds of their illness or the day-to-day, the tests, the blood tests, the next thing to do. They really had to see the big picture of the story, that overarching story, pattern, and every illness has a pattern. And it's about leaching that information out from the healthcare team. So being able to zoom out and then zoom back in as appropriate. But that context of the storyline was critical for them to understand where they're at and what comes ahead. And with that came this knowledge that people who had a better experience knew their style, how they like information. They did not just sort of give in to that the disease, reorient their life around the illness, but they were able to infuse or to recognize their own coping mechanisms, their own choices, their own coping mechanisms of how they are in life, and bring that or lean into that, because that was only going to sort of be amplified when they face crises, and that of their team for the matter. They needed to customize their order, which is thinking about what was important to them, their values, and bring that to the forefront, talk openly about that, so that the standard of care, this conveyor belt of healthcare, they could make choices that fit who they were, and that it wasn't only doctor knows best. The doctor knows the disease the best, but you know yourself the best. So being able to recognize that you have an important role to make choices along the way that fit who you are. Expecting the ripple effects, which is recognizing that a patient doesn't journey on this alone. They have people around them, their inner crew, often, their family or their chosen family. There's a ripple effect, and they also need to be thought about and considered and brought into this. They have to do all the same things. Tag your it, their role in connecting the dots in a system. Every system has gaps in it, and inviting the confidence to invite yourself into the conversation, the courage to do that. Because if you don't, you will sort of, get swept away in the tornado of what healthcare is. So we kind of deconstructed. If you really think about what palliative care is, it does a lot of these things. Of course, it does symptom management as well. But if we go early on, these keys are what is the essence of just good care. Let's not necessarily call it palliative care. Palliative care specialists do this very well, but so too can many people, your family doctor, your community. So everybody has a role. It's everybody's business. It's the people who are part of the Palliative Care Society of Bow Valley. You could have a role in helping people to navigate this, and helping people know these skills is a piece of it. So when we thought about those skills, how did we get the word out? We realized we were creating a movement. We called it the waiting room revolution, because it is a revolution. It is about changing the way we see patient and family role in this process, and the waiting room as a place where we're anxious and nervous and waiting for news to happen to us. But we're trying to flip that around so that we have an active role in changing the story, the experience. We may not be able to change the disease always, but we can change the experience. We put those 7 keys into a podcast called The Waiting Room Revolution, the website. Season 1 has those 7 keys with patient stories, sort of that infographic. And we are now in season 4. Kathryn Mannix was on our season 2 and our season 3 when we were talking about both their books, right? With the End in Mind, Listen, both of those are fantastic. You'll hear more of her stories and her beautiful storytelling there. But we are expanding who we're talking to, not just palliative care experts, but veterinarians, social workers, people who, child life specialists, patients, families, all different kinds of illnesses, mental illness, mental health, etc. So we're trying to expand this idea of what could a good patient experience could be. And so that's what Waiting Revolution is about. We joined social media because that's where patients and families were at, including TikTok, which has been interesting to get the message out to where I guess people are at. And we're excited to have a book come out next year in the fall that we're working on to try to encapsulate the stories and also the lessons, and really as a how to help people really have a take charge of their experience in a more of a guide way, not just in a podcast format. So I'll just end with a few key lessons in this process, and I'm happy to chat more about, you can notice that I haven't really said death and dying in palliative care, and I don't think that's in contradiction to what we just heard, because I think absolutely we should talk about things openly. I just think how I've sort of reconciled this is when we go so far upstream where we're really trying to help people, even at the beginning of a diagnosis of a life-changing illness, which could be like years, like 5 years, 10 years. There's a lot of time between that and, you know, the different stages. There are times we're meeting people where they're at. I think at that point, they may not want to be using the words palliative care, death and dying. They might be open to metaphors, analogies, and that's what we learned. As we move in and they understand where they're at, this is when we can talk, well, openly, if with their permission, about what it means. So it was really about sharing the power and this power imbalance between the system and patients and families so that they could have an active role. I think we figured we were on something when we thought, you know, providers would be sort of, you know, angry that we were talking about this, but they actually were like, yes, show me how to do this. This is language I could use. Patients and families were saying the same thing. They liked these walk two roads, zoom out. They understood what it meant immediately. They weren't intimidated. It was a way to enter into the conversation, invite them to the conversation, to meet them wherever they were at. And if they wanted, you know, if they wanted to learn more about palliative care or what will death and dying look like, excuse me, that then they had we had opened the door. The language was critical to building our community. And I think it will be for your region as well. The metaphors we found helpful. I don't think we were thinking of them as euphemisms. We weren't avoiding talking about that. We just thought the metaphors were sticky and people would understand, like zoom out. They understood what that meant and they could understand what we were asked, what they could do to have a better experience right away. And lastly, we're hopeful. These things are presented in a way that is hopeful and positive, which unfortunately, as much as we've tried, and I think it's critical that we have a global discussion with communities about ordinary dying is a part of this. But for many people, they still think palliative care is just with death and dying. So how do we make this into a hopeful thing? How can we move it upstream? This is what we were really trying to tackle. And I think our journey has been, part of the answer to do that successfully. So thank you for those few minutes, and I'm going to pass it over to Bill to continue the conversation.
Thank you, Dr. Seow. And I realize, after really enjoying immensely what you just said, I didn't introduce you, really. And I want to take advantage of that now in retrospect, just to let people know that you are the Canadian Research Chair in Palliative Care, Cancer and Health System Innovation, an Associate Professor in the Department of Oncology, an Associate Member of the Department of Health Research Methods, Evidence and Impact at McMaster University, and somebody who's dedicated research to health services and policy, quality measurement and improvement, population-based analytics, program evaluation and quality indicator development. And all of that background is what you just gave us in very lay people language that I'm so tremendously grateful for. You've worked with numerous health and government organizations, including RAND Healthcare, Ontario Ministry of Health and Long-Term Care, and Health Quality Ontario, and of course, health policymakers within the palliative care realm. And you apparently got a BSc from Yale and a PhD from Johns Hopkins. And you just look like such an ordinary guy to have in the living room with us. So 10,000 thanks. We're going to move on to Brian Callaghan, who lives in the Bow Valley, or did. I think you said you moved, but we'll find out. A great supporter of Palliative Care Society of the Bow Valley. And a few years ago, Brian's wife died, Helmi. She spent her last days in hospital, and he was with her. And since your passing, or rather as Kathryn Mannix would encourage us to say, her dying, he's dedicated himself to ensuring that end-of-life palliative care becomes a reality in this part of the world for any who need it. And he truly believes we can do better for the memory of those who've died and prepare ourselves for our own dying and a whole generation's dying. And so with that, I welcome you, Brian, to this conversation and look forward to hearing your story.
Thank you very much, Bill. I'm going to say good afternoon to everybody, given our time zone here. Bill, I'm still in Canmore and I intend to die here. So that will set the marker. What I wish to say to people is, as Dr. Mannix had used a story to talk about some very important attributes, and I call them almost waypoints along one's life journey, death as the inevitable outcome of it all. But from the time that a very young woman, my wife, was diagnosed with brain cancer, literally the relationship with life and dying now comes into full focus. My children at the time were 3, 5, and twins, 9-year-old. I had in-laws who were still alive, brothers and sisters. Everybody was impacted by what we'll call the scientific medical diagnosis. In the beginning, there was this notion of what are my chances? What are my odds? And a kind of a preoccupation with understanding, quote unquote, the science. But very quickly, we realized that our life was impacted in multiple ways. Multiple ways began with my wife, who was a school teacher, had to give up her career. We had an interesting conversation about what that meant to her and what that meant for me now as what we'll call the sole breadwinner in that old traditional model. But it spoke to the beginning of a transition at a deep psychological level. In the beginning, one starts to almost look at time as something that we don't have the poetic relationship with time in terms of we have lots of it. Now the reality is we're not sure how much we have, and depending on how things go medically, it will lead to a shortened lifespan. Our experience through that was supported by a fantastic team of medical people at the Tom Baker Cancer Center here in Calgary. They had a great counseling department, which we took advantage of, both personally and as a couple, and then eventually as a family, as we accepted that this conversation needed to involve the impact this was going to have on our children. And it did. It had an impact on all of us in a very personal way, even our interpersonal reactions. Some of our children developmentally felt it hard to express affection for their mother. They were fearful of death. So we had to work through those kinds of sentiments. At the same time, my wife, Helmi, was very practical. She wanted us to plan everything right down to having us go with her to the cemetery in Canmore and pick out where she wanted to be buried. So we were very upfront about that. We didn't shy away from those kinds of decisions and experiences. If anything, she felt she wanted to involve all of those who loved her. In the beginning, she had a reasonably good quality of life, and she was a very positive person in that she said, "I'm not dying of cancer, I'm living with it." So that became our mantra. That became our family symbol of taking on what you have been dealt with in life and doing the best with it. So we still planned holidays, we still planned family events, but we always planned things with a very short runway in front of us. Toward the back end of her busy life, when they tell you at that moment that you have been living with for a long time, that there's nothing more we can do for you, It's the old cliche of go home and get your affairs in order. Well, we had a lot of those affairs already in order, and those were all of the practical details of what we would do with our temporal existence. What she wanted to plan now, and this was the interesting part of that expression of it takes a village to raise a child. It also takes a village to take us into our afterlife. What she wanted to do was actually plan all of those things that are normally left to grieving friends and family at the end of life. She wanted to plan her service. She wanted to plan a living funeral, which she did, and invited her friends. In a moment that I found rather surreal in this journey, she actually met with a group of friends, both from our local church here in Canmore and the music community, to plan her order of service and all of the music and songs that were to be sung, and all of the little pictures and artifacts that we would use during that service, while I was at the kitchen stove making supper, as if it was just another day of ordinary everyday life. And yet it was the most heart-wrenching experience I had gone through at that time. The living funeral was interesting in that people were able to say the kinds of things they tend to tell you in a card after the person's gone, but they can actually say them while the person is living. And that was a great infusion of love and dignity and respect for her, which I think helped her enormously. By the time we were doing that, she was only a couple of weeks away from dying. Toward the very end of her life, it is as Dr. Mannix described, in terms of we had received very good information on what death looked like and what death sounded like. Some of the experiences in dying in a acute care hospital were not the things that one wants to ever experience. Confusion with staff not knowing who they were dealing with, change of staff, shift rotations, things like that. To the point that I started to take note of these things that were the not good experiences that Dr. Seow has talked about. And I made sure that I passed them all along to the hospital administration from the point of view of we can do better. Going through it now, I realized that as a lifelong educator myself, I too had a responsibility to carry this learning experience into a transformational place, to bring it forward with a group called the Palliative Care Society to advocate for better care, and then, of course, to advocate for a facility. Along that journey, of course, we were offered palliative care in Calgary. My wife took the view that here's my family going to go through the most traumatic experience of its group as a family, and they'd have to be on the highway in the middle of the winter to do so. So she accepted to stay here in her hometown, which was of great comfort to her. Her parents had raised her here. They had lived here. Her mother had been born here. And quite literally from her hospital room, she could see her place in the cemetery that awaited her. So it was interesting to follow that storyline for her, because it gave her a sense of fulfillment of the journey of life. And by bringing us close into all aspects of it on a level of truth and not euphemisms, we were able to, I think, deal with it as best we could as a family unit. Toward the end of her life, when we were with her every moment of the day, she gave me a list of people who she would like to have in the room or spend the night with her. These were the people that I had to accept were as close to her in caregiving as I was, and I had to rely on them because I just couldn't do it 24/7. So in the end, these people played a very different role in our life, just beyond friendship. And they spoke to me after the fact as to how moved they were to be included into this inner circle. So when I look at these kinds of attributes, I see them now as all things that we can pass along to each other, acknowledging that everybody's death will be their own personal experience, their own family experience. But there are things that we can notice that bring a certain sense of relief through the whole process. I had to step away from thinking I could do it all and accept that. And even with my children, when they were saying, Dad, I'll stay with Mom, you go for coffee, we actually talked to staff about what it may be like if we were the one in the room when she did die. And that was very, how should I say, confidence giving in that it was finally a son, our son Alex, who was with her when she did die. But he had talked to me and his uncle, who is a doctor, about what are the sights and sound of death. And he said it was a very moving experience to be there with his mother. So now I look at our work, and it's a mixture of our stories, our experiences, the realizations that it is going to come into our life sooner or later. It could come anytime, either in one's 95th year or in your 15th year. The way we will care for each other as a society and as a community, to me, is an attribute of that aspiration of it takes a village to raise a child, and it takes a village to say goodbye to that child as they grow into their years. So my journey now is to take the learnings. I'm now starting to read a book that was recommended by Dr. Mannix, My Uncle's Wake. It just arrived through Amazon the other day. So I look forward to adding to my vocabulary and emotional and life experience on that basis. So I want to thank my two colleagues for giving it a different context than our family experience. So thank you very much. And Bill, back to you.
Thank you, Brian. Much appreciate your vulnerability in sharing a really very real and very raw and beautiful story with us. We have opportunity to engage these three pieces, Dr. Seow's perspective and Dr. Mannix's and Brian's. And so we're just going to kind of flow with this. I invite the three panelists to touch on pieces they've heard, and we'll also have opportunity to address some questions from our participants. So just before I go to Q&A, Dr. Mannix or Dr. Seow, just as you've been listening to each other and Brian, I open it up to you all. Oh yeah, now you're shy.
I'm struck by the common theme of knowing what to expect, being prepared by knowing more rather than by knowing less. And whether that's knowing more from as far upstream as you can get with the waiting room revolution, of which I'm an enormous fan, or whether that's just the trust that Brian was able to have with his children, that it was okay to describe to the children what they might see as Mum is becoming unconscious, as her breathing is changing. If you're the person who's in the room, what might that look like? Because once you know that, and I've had so many letters from people saying this, once you know that, you can be in that room with confidence. You can say, oh, this is that thing they told me about, rather than what's that noise, what's that breathing. It's so important. So isn't it really interesting, that common theme through everything that we've said from very early on, right down to the moment of dying.
Kathryn, if I can add to that, one of the things that was interesting, it's almost, you're almost embarrassed to ask. I don't know, maybe children are a lot more innocent in asking questions, but I found I had to get over this inhibition of just ask. Just ask. They'll tell you if you ask. It's a moment of shyness or embarrassment. I don't know what you'd call it. You may have seen it in others, but I certainly was never denied an answer upon the asking.
Yeah.
Yeah, which is the whole, oh, go ahead.
I think it's important actually that clinicians offer that we shouldn't be waiting for people to ask.
Okay.
Sorry, Hsien, go ahead.
Yeah, I think I was going to say the same thing. That's the whole invite yourself to patients and families. And what we say to providers is please invite people to the conversation. Because we are, you know, what we've heard from providers is that they're waiting for patients to ask if they have questions. And in your book, Listen, you talk about how we can reframe some of those questions to be more open-ended and actually allow people to that are helpful and not sort of closed off. But I think where I also saw the commonality was the idea of what I think the society is trying to build, you know, the Palliative Care Society of Bow Valley. You know, you're really in many ways a collection of people who are trying to, maybe I'll use the word compassionate community, but a community that cares for each other. And I'm looking at a lot of the comments in the chat. It's not just about healthcare providers. It's not just the system of, as in the hospital system or the home care system. I'm thinking our community is everyone. You are part of that community. We are part of that community. You know, the clinicians, healthcare providers, but the pharmacists, the social workers, the teachers, the funeral directors, they are part of the community. So if we are concerned that the experience that we have is not what we want it to be, then what can, I mean, I guess this is why you're coming together with events like this, is what can we, how can we support that dialogue to help you change that and build a community that you want to be a part of, and that will change the experience. So I really think that, you know, talking about ordinary dying, knowing what works, living funerals is a beautiful cultural innovation that could spread. You know, it could happen at every birthday, but these are all things that can happen when we are aware and in the know and not scared or just sort of no one wants to talk about it.
We have a couple of questions I'd like to throw into this mix. They're very pertinent to the intersection between the three perspectives. And I'm going to start with one of the first ones that's been thrown in. And I guess I put this on, I don't want to go too far down this rabbit hole, but I think it's an important piece for us, especially in Canada. And Carrie Lynn asks, here in Canada, medical assistance in dying is legal, and legislation for it is gaining momentum in the UK. She's wondering if Dr. Mannix's take on what her take is on assisted dying, and where it falls for her on the continuum of palliative end-of-life care.
Thanks for that question, Carolyn. So I think it's really important that I say from the very outset that I am not taking a public position on assisted dying in either direction. And that's because I'm trying to do something that I think is much broader than the assisted dying question. Wherever it is made legal in the world, the numbers rise until they plateau off at something like between 6 and 10% of the population. But dying is going to happen to 100% of the population. And I'm really, really clear that what my mission is about is people understanding what the process of ordinary dying is. You're right that there are increasing waves coming through the UK Parliament. We know that public support for assisted dying is growing around the world. I don't know how much of that is because of fear of what dying might be like. And I mean, I don't know. So again, to try and fill that void so that people have good information, accurate information they can draw on that helps them to form an opinion so that they are deciding with good information is an important part of what I'm trying to do. And clearly, if I were to say, well, actually, do you know what? in my heart of hearts, I think that assisted dying is a great thing, or, oh, you know, I've got huge reservations about assisted dying. If I were to say that in either direction, the rest of what I'm saying would be misinterpreted as some kind of persuasion. So all I'm doing is bearing witness to what I've seen in palliative care practice over 30 years, working in palliative care teams, which is a little bit different in the UK from Canada, but not hugely different. There would be quite a big team and half of a doctor for that whole team, everybody carrying caseload, but the doctor is the same doctor for everybody's patients. So over that period of 30 years of palliative care, the teams I've been working with have looked after somewhere between 10 and 15,000 people at the very end of their lives. So I'm bearing witness to what I've seen, and it's important that we don't say that all ordinary dying is comfortable. It isn't, but it's rarely awful suffering. I can think, say that was 12,000 deaths on average, I can think of about a dozen people where I thought, this is really terrible. If this is happening to me or somebody I love, I would find this really, really hard. But the need for assisted dying to escape from difficult ordinary dying, I think is actually very small. I think there's a different problem, which is how difficult it is to live with an illness that makes your quality of life very difficult, and where you're in fact not dying. And there's a long time to live with a very, very difficult illness. And in fact, the way the UK is framing its potential laws, those people would be excluded anyway. So I think there's still a much, much bigger conversation to be had. And the conversation currently is not framed gently. It's not framed with the two sides, both completely motivated by compassion, really listening to each other. And the discussion, certainly in the UK, disturbs me profoundly. I know I'm not giving you an answer. I think that's because in 30 years and 10 to 15,000 deaths, I've worked out that I really don't know what the right answer is.
I really appreciate that. Thank you. And I know it's as complex for us in this country, even with the legislation in place. I have a comment from Lynn. She said, could you please give your perspective, any of you, on the topic of, if we talk about it, will it take away from living now with someone who may not be used to speaking about it? If we talk about it, will it take away from living?
If I maybe just throw in a quick answer to that is, no, what we found is the opposite. This is walk two roads. We're hoping for the best, we're planning for the rest. The more, what Dr. Winemaker says, what I've seen, born witnesses, the more that people talk about what they're afraid of, that actually they are actually the fear, the anxiety of not talking about, of what they weren't able to talk about is revealed. This is the whole ordinary dying. When we understand what it is, the fear is gone. In fact, it helps us to live better, to use the time better. Their hope, they actually have more hope because the hope evolves into something that is grounded in reality, as opposed to this false reality. And then when that doesn't happen, there's all these other feelings of resentment and anger, etc. So when we are able to ground the hope in true of what will happen and prepare for it, or at least to understand it, it is actually a better experience. There's, you're able to live better. I don't know if, Ryan, you felt that by knowing you could appreciate the time better.
I would echo that sentiment. Now, it may be a family attribute, but certainly in this family of educators, I mean, I call them my children. I mean, I have twin daughters, they're lawyers. My son's a police officer. The other fellow works in HR. You're not going to pussyfoot around this conversation with people like that. But look, you approach things from most of us I want to know. Knowing will not relieve your grief. I'm not saying it's a panacea, but it helps you understand what you're going to experience. And if the vocabulary is a bit stunted or unknown to you in the beginning, I can teasingly say with Bill here, on this particular topic, if you talk to me about mixed glioma astrocytomas, I'm a bit of an idiot savant, but I don't pretend to be a medical doctor, but in terms of understanding what I needed to understand, what my wife's journey was, knowledge empowered me to be a support to her. I understood the journey. I can't tell you anything about ingrown toenails, right? That it's just where you go. It brought a measure of relief to me to understand. And the other thing I wanted to add on here is that when one's loved one dies, the palliative care philosophy is not over. There's the afterlife programming that goes on to make sure that those of us that are here are okay. And I know that sounds rather soft and mushy, but that too is very important. And the other thing I've realized in my own personal journey is I was very unmoved by people who use the word, so now you can move on. I haven't moved on. I've moved to a different place with my grief, with my love. She's still going to be. I love Nana because that's what she was called to. It's a great word. And you still carry that forward, but the relationship with grief changes and your ability now to help others changes, and maybe it becomes manifest in your own personal destiny. But knowledge to me was key, and both of you have spoken to knowledge gaining and knowledge sharing as an integral part of what is out there for all of us. Thanks, Hsien.
Can I just add one thing? I think what I just wanted to underscore was there's two things that we can be getting knowledge about. You can get knowledge about that you will die, what that looks like, the death, the dying. Yeah. And some people want that and some people don't. And I think when they're dying, we shouldn't be afraid to talk about it if people want to know. But the other thing that what we found is what all people, or the vast majority of people want, is they want to know what to expect in the different stages of the illness, not just at the final end stage, the final stage or the late stage, but in the middle. And when do I know from the beginning to the last year, to the last months, to the last weeks, those stages and all the decisions along the way, you might be curious about the storyline and maybe not want to know about the timeline, and that's okay. So there's different kinds of information that people want.
Yeah.
I have a bit of a follow-up question to this current discussion. What do you do if your doctors refuse to discuss what is coming and how and what to expect? And that's from Moira. What do you do if your doctors won't discuss this?
That's incredibly difficult, isn't it? So there are things that are different about our healthcare systems, but one of the things that is the same is a kind of medical reluctance to name how difficult things might get, almost as though it's magical thinking, almost as though if I tell you how bad things might get, that might make it happen. So I think that finding a way of getting the doctor to be the doctor that you need is really important. And you don't always have the option of changing the doctor, do you? If you live in an area where this is the specialist in the condition that you have, you can't go and consult somebody else. That's the person that you need to talk to. So perhaps it's about being able to send a letter in anticipation of your clinic appointment to say, last time I saw you, I didn't feel my questions were answered. I'm the sort of person who likes to know everything. Please don't spare me. I prefer it if you say it kindly. I'm going to bring somebody to look after me, so you don't have to look after me. You just have to give me the information. I'm sorry that you might have to look after your doctor, but you might have to look after your doctor to get the doctor to be the doctor you need her or him to be. And this is exactly what the waiting room revolution is about. Hsien, you must have something to say about this.
Sorry, I was nodding my head. I mean, it's also what you talk about in With the End in Mind, the idea of inviting yourself to the conversation, but you have to give your doctor permission to have this conversation. Exactly what you said. Sammy coaches, or in our waiting room revolution, we say, tell your doctor, I'm the kind of person who likes to know. I understand this is a disease that's I'll have for the rest of my life. I want this information. It's going to help me feel better. Don't be afraid that you're going to hurt, make me give up hope. Like name call out the feelings, just like I would with my, my young children. You name the feeling. Like, you might think that I'm going to be sad and depressed. If it's bad news, don't worry, I'll be okay. I'll know how to deal with it. But this information is going to ground me. It's going to help me. So please be open and honest. If they are not able to, then you can, I think, especially for your family doctor, you might say, if, you're not the kind of doctor who is going to make home visits or is comfortable with this, then what does that look like when I get to that stage? Are you going to transfer me to another doctor? Have those conversations up front, because if they are not the kind, if they're not comfortable with this and are never going to be, maybe you would make some decisions about changing your care. I don't know. But the key is give them permission to be honest with you, because they sometimes are afraid that that's not what you want.
Yeah. We went through a personal experience, as many of you can appreciate, when you live in a small town. The doctor who was tending to my wife, they had grown up together since high school, and he had actually delivered the son who was with his mother when she died. And he too was having a personal relationship, not with his patient, but with his friend. So it was difficult. And at times I used to say to him, I won't use his name, I used to say to him, it's okay, I get it. I understand you're on a journey too. You don't try to protect me. I need you to be the doctor too. And we were good, but I realized too that he was having a personal experience with this, and that's okay. I mean, I actually looked at it as a bit of a plus, that she wasn't just a number, just a patient, the lady in room 10, that kind of thing. So, but I agree that I love what Dr. Mannix had to say about you need to find the doctor you need at that time. And that might be a difficult kind of personal decision to make, but sometimes having an advocate is good also, So anyway, enough said.
A couple of comments I want to share. Oh, go ahead, Dr. Mannix, sorry.
Just that advocacy thing, Brian, I think that's a really, really important point. And so 2 things to say here. One is, in a moment, we need to just shift back into remembering that dying is a personal, social, family event, not a medical event. And we need to be really careful that we're not medicalizing dying here. Mm-hmm. But there is medical care alongside us when we are ill with an illness that will eventually shorten our lives. And sometimes it's not the doctor whom we see most often, but another healthcare professional who's best placed to be either our advocate with that person to get better information. Might it be the family doctor? Might it be a member of the support team, palliative care team, hospice team, who will prime the doctor who needs to give you more accurate information? Or might it be that actually that doctor just can't have those conversations with you, but can send very rich and detailed letters to other people who are involved in your care, who can have those conversations with you. Don't choose to have the conversation with the person who makes it most difficult for you. Choose to have the conversation with the person who makes it the easiest for you and gives you the information in the way that best suits you. Go onto the Waiting Room Revolution website and just have a look at the resources there. There's such great ideas for ways to help the system, to help us to get what we need from it.
Yeah, I would just say that's a great point. Maybe the person who best can help you understand what to expect next is another patient family who's living it. This is what the society can do, is connect us with other volunteers, or the Dementia Society or Alzheimer's Society, or the Caregivers Alberta. There might be other people. It's not only the doctor who might have the information that can help you.
I have another question related to this, and we're really getting quite wonderful inquiries and comments, and I think more than we're going to be able to satisfy in the time that we have left. And I apologize if we don't get a chance to share your comments or questions with the panel. One person stated, what you're saying requires the patient to really understand their own situation. Some don't know the type of questions they should be asking. So what's your thoughts on that? If you're in a situation where you don't even know what it is you should ask your medical team, where do we go from there?
So I say this is the waiting revolution. We said, you know, hey, what you say is, hey doc, I want to walk two roads. I want to hope for the best, but plan for the rest. And I'm know your style. I'm the kind of person who likes a lot of information, or I'm the person who likes to be in the woods day to day, but my partner is the planner and they need to know what's happening. And so please, you need to have a talk with them. And I think zooming out is key. Again, you don't have to know every detail, but the storyline. What is the beginning, the middle, the late and end stage of my disease, and where am I at? What will that look like? You don't have to know all of it at the beginning. What's the next stage? And what are the decisions? Like, what is not just the trajectory line, but the narrate the story, like what's going to happen to me? That's what people are missing. So that's what I think you can always ask about at every point, or really you should have that context. It's not about the secret questions. It's about just understanding the storyline of your illness, because that overarching pattern for your disease is known. And so that's all you need to ask about is help me understand, what does that look like? Because most of the time we're just in the next appointment is 3 weeks, the blood test. I don't know why I'm doing this test, but they said I need to, and I have to drive, you know, all that stuff, but not the meaning making of the information we're getting. I think once you have that context, all the other decisions, your advanced care planning, all that fits underneath that. So that I would say is the most important piece.
Yeah, I think that's really wise. And I noticed there have been a couple of comments about people who want to not know. And so I'd like to just pick that up and talk a little bit about not knowing. Not knowing or denial is a really great way of maintaining your emotional calm. If you don't believe this is happening to you, then you don't need to experience any of the emotional waves that are associated with it. Now, there are people who cope with absolute denial from diagnosis to death. It's very unusual, but some people can do that. It is incredibly difficult for their village when they do that. Because you can't talk to them about how sick they are. You can't say goodbye. It's very, very hard, but it's a way of people maintaining their emotional integrity. And we must respect that that is their choice. I once had a patient who said to me, if it's bad news, doc, I just want you to tell my wife. And so he recognized in himself that that was the way he wanted to deal with things. And we had a conversation that said, well, okay, help me out here a little bit, because obviously when it's good news, I'm going to want to tell you good news. But the day that you come and I can't give you good news, you'll guess it's bad news, but you don't want me to tell you. What conversation will we have on that day? And so the agreement we came to was that I would never give him any news. I would only talk to his wife. And she navigated that with her sister as her support, because obviously, ordinarily, her husband would have been her support. So families can identify the way they want things to work, and we have to not try and overmanage it. People understand themselves, and we need to be humble enough to recognize that people are the best judge of what they want to know. On the flip side of that, what question can I ask? I teach junior doctors to ask the question, tell me, when you think about this illness, what's your best hope and what's your worst dread? So that when we're looking after you, we can try and engineer things so that they're the least like your worst dread and the most like your best hope they possibly can be. I think you could turn that on its head and go to the doctor and say, do you know what, doc, I have a kind of best hope and I have a worst dread scenario, and it would really help me to just explore that with you, because I think as Hsien says now, you can think about what are the phases of the illness. There's a question here from somebody whose father has dementia, is living in residential care and can't remember why he's in residential care. And the difficulty with dementia is that even if we explain today, by tomorrow he still might not be able to remember again. But early on in the illness, to have had what it looks like now, still able to do loads of things, still got enough brain function to make lots of important decisions, appoint your attorneys, write your will, talk about what really matters. And then later on, perhaps not able to recognize those things, but what will matter most? If you can still recognize and appreciate your family, for example, how will that be? And then later on to understand that one of the problems in dementia is not just memory, but the parts of the brain that control the rest of the body start to fail. And swallowing is one of the things that becomes lost. What will we do when the brain no longer tells the throat how to swallow? Is that a point at which we stop feeding? Or is that a point where we go for tube feeding? That's a huge decision. You can't make that if you have dementia at that point. That needs to be a decision that you've made when you still had capacity to make the decisions. So helping people to understand the story, giving them the decision points, and then respecting as much as we can the decisions they made in advance as they walk along their illness pathway.
I'd like to add to that in terms of, you touched on something very interesting, Kathryn, when you talked about don't tell me, tell my partner. We realized early on that even though I was the husband playing the support role, when I was sitting in the meeting, I was as emotionally upset as any other person. So our strategy was we always brought a friend to take notes, because when you're receiving the information, it's as if you're in a tunnel. And I'll say to myself, you're not really hearing properly. You're emoting, you're taking it all in at a very different sensory level. And cognitively, we'd be driving home back to Canmore. It's an hour's drive. And we'd say, do you remember what the doctor said? And we found they were going, well, I think it was this, I think it was that. So we had to come up with a strategy. That strategy then allowed us to then review the notes that the friend would take, the scribe, and come up with questions that we could formulate related to what we had now heard and understood. So a little bit of a different strategy, a coping strategy, but it served us well.
Can I pick that up with you, Brian? Because I'm a great advocate of end-of-life doulas. End-of-life doulas are starting to make their presence felt across Canada. We have several organisations in the UK, and I'm patron of End-of-Life Doula UK. I'm very proud of that. But for people who haven't heard of them, this is about training members of the public. They don't need any medical background at all to be end-of-life companions, the sort of person who might go with you to your outpatient clinic and be your scribe, the person who understands the process of dying and can walk around your house with you and think about what will work well and what might not work so well. If the bathroom's on one level and the bedroom's on a different level when you're not walking around so easily anymore. The person who can be the companion who's supporting the family and making sure that there are meals at meal times for the children, for example, as the family becomes more distracted by the illness of the dying person, and who will be part of the vigil support during the very end of somebody's life and into bereavement support. And I just wonder whether the community hospice organisations also have a role to play here. Is this the sort of thing that your association in the Bow Valley would be able to offer to each other, to have volunteers who might be the person who scribes at a doctor appointment, or the person who comes out to support with shopping or housework or those sorts of things? Because somebody made a really important comment, either in the comments or in the questions, about people with a small village finding it really difficult to cope. And their comment went on to say some people are opting for MAID because of that, which is their right because that's what the law allows. But it would be awful if somebody was backed into that position rather than voluntarily choosing that position.
We didn't have it available to us at the time, but certain community leaders stepped up to do that kind of stuff, Kathryn, organizing meals and those kinds of things. Had it been made available to us, I would have given it very serious consideration, because at that point, you're juggling a lot of things. What we found is that when my wife was still at home, we were assigned let's say a worker to work in the home, but to be with us like in a counseling role. But the moment she transitioned to the hospital, they wanted to assign somebody else. I said, we're emotionally exhausted. When you bring these people into your home and they now become intimate to the tears and the crying, and there's a lot that's going on here. You don't have a lot of time to welcome new people into that emotional space. So I pass that along to, we'll say, our hospital administrator as we can do better. But I have heard of the role of this doula in the same way we have birth, why not death doulas? And I don't know, Bill, if there's something to add to it from your perspective. I wouldn't have knowledge of that at this point, given our locality here.
Yeah, that's really interesting. The death doula movement, let's call it, is certainly expanding across Canada. Mm-hmm. And we have some people in our PCSBV team that have done death doula training.
Oh, okay.
Yeah. And in some part, I want to respond very quickly, Brian, to what you just said about, the chaos of people moving into your life. You get connected to certain people and supports. And a part of what our volunteers are doing, our client care volunteers here in the Valley, is stepping into the lives of people who are on this journey, either with a diagnosis and their families, or their grief companions to these people. But they recognize they could be in for the long haul. They might be inserted into a family's life soon after a diagnosis, and they might be looking at a 4 or 5 year journey with that family into hospital at the end, or a hospice. And a part of that commitment is, let's reduce the stresses involved in the chaos around a diagnosis. And if we can have a support person there that is a through line for them right to after death, so that the grief companioning, that can be a real gift. I want to throw one question out, Brian, direct specifically to you in our last few minutes, and then invite Doctors Seow and Mannix to also reply. And the question is from Heather, and she says, I'm curious how old your son was when your wife died, as he was with her when she died, it sounds like. She says, I believe you mentioned your children were quite young. I feel society tries to really shelter children from witnessing death. And to everyone, any thoughts about talking to children about death?
Mm-hmm. On a very personal level, I said when my wife was first diagnosed, the children were 3, 5, and 9. She lived 22 years with brain cancer. She underwent 7 craniotomies, countless rounds of chemotherapy. The children became very knowledgeable. We used to actually bring them with us to the doctor's offices for consultations. At one point, you discuss what are my chances. Well, what they gave us as early chances turned out to be wrong. She outlived their predictions by many, many years, to the point that they thought she was a bit of a medical marvel. But along the way, these children are growing up with a mother who is living with cancer. So by the time that it happens that this son, who's now a police officer, is with his mother, he's in his late 20s. So he has seen his grandparents die, one at home. He had perhaps an experience that Dr. Mannix would say, good for him, because it's the way it used to be. And he was well prepared for it. So today he talks about it as if it was his privilege to be with his mother in the very same hospital that she gave birth to him. So it has a poetic, I think when I write my compendium to, my father's wake book, I'll be able to add that dimension of he's one of the few people who has that generational experience. So it didn't happen young, but we made a deliberate choice to involve our children at what we will call here age-appropriate information. We always wanted them to know that we would speak the truth to them, so that they wouldn't be susceptible to community. The negative is gossip, but in a loving way, the community interest in your story. We wanted our children to have their truth from their parents. and always come back to us for a source of that. And I think it was the best we could do, given the fact that these children were living with the notion that their mother, had a serious illness.
Yeah,
Thanks,
thank
Bill.
you for that. I'm aware of our time. And so I'm going to say to all those that submitted comments and questions we couldn't get to, if you so desire, feel free to connect after the webinar direct with me by email. And you can email me at bill.harder@pcsbv.ca. And they've been rich questions. I really, if we could take a coffee break and come back for hours and not be done, but then Dr. Mannix, of course, is something like 25 hours ahead of us, and she needs to go to bed. So I want to leave the last moments just for, say, a 1 minute and 33-second closure for each of you. And Dr. Seow, I'd like to invite you just to start that off. And I'm throwing you under the bus here, but as you've listened to the conversation, what's at the top of your thoughts?
I think there's a lot of commonality. We're really talking, the same, from different perspectives, but all on the same side of the coin. Ordinary dying is an important movement to help people, citizens of the world, of society, of communities, to not be afraid of this natural process. The waiting revolution is work to try to help people to get information, to deconstruct this palliative care approach without using the words palliative care, so people can get it, even though they're being told they are not ready yet. They can still reach out the information they need so that they can prepare for the different chapters of the illness all along, because every day we're getting closer to the one inevitable, but that's not necessarily what people want to know. So or how people want to frame it. So I think the last thing I would say is this community that you're building, whether it's virtual or the people in Kenmore, like, you have an opportunity to think of ways to support each other, other families like Brian's, and think of ways that you can invite people to build a community, passionate community, and resources, and a place where you can gather to be an enabler to make a difference, because that's the biggest way we can see change, not through hoping that the hospital CEO sees the light or what have you, but to make real change for the people in your community. And each of you have a role in that and have knowledge to support each other. So palliative care isn't just reserved for specialists. It can be provided by listening, by providing bereavement support, et cetera. So that would be my piece, that you each have a role and actually have a lot of assets that you can leverage to make things better tomorrow.
Thank you for that. And let's tie in Dr. Mannix, your thoughts as we close, and then I'm going to go over to Brian for the last word from that side of the gurney.
I'm just watching the comments coming up and just seeing how much people appreciate talking frankly about something that really needs frankly to be discussed. So I just appreciate that people are here and that we're all looking after each other here. But in a moment, we're going to close this line, and some people may be left with things that are brought to your minds that are making it sorrowful for you right now and reminding you of difficult things. So take a moment to think, what will you do when we say goodbye? I was going to say good night, but that will only be from me. Personally, next I will make a cup of tea. But who can you call? Who can you talk to if you're left feeling uncomfortable? Because it is important we think about these things. We can take the fear away by understanding it better, but we can't stop it from being sad.
Yeah.
So if you're left feeling sad, I'm sorry, I'm grateful to you for having the courage to turn up and listen to us. Please look after yourself when we close.
I deeply appreciate that reminder to all of us, Dr. Mannix. And if this does activate something strongly, please feel free to reach out to me. Within my capacity, I will respond to emails or contacts in the today or the days to come. Brian, we look to you and your very incredible story that brought together what Dr. Mannix has given us and what Dr. Seow has given us. And what's your last word for us?
I'm going to sound like John Lennon here. It almost is all you need is love. Let your community love you. Let your community carry you. Let your community bring the lasagna to the front door. My wife used to say, they're actually not praying, they're doing something. So let the actions happen. The other thing I had to accept in my heart of hearts is that this person was loved by so many others, and they needed to express that in some way, and they found their way. So I had to prepare myself for that because, as Dr. Mannix said, some of what they wanted to share with me was their sadness. And that's the kind of echo you have of that grief in the immediacy of things. But I would say to anyone and all who will have faced this part of their life journey together, seek out as much as you can find with the resources that are there and becoming more readily available, I guess demystify as much as you can. What you're about to experience. The sadness will come, and that is part of it. But the thing that I remember the most is when it was over and the ceremony was over and everybody drove away, I sat home alone, and my refrigerator dropped a tray inside the internal mechanism, a tray of ice cubes. And it was the only sound in the house. And I said, now it really begins. So it's this notion of, I said earlier when Dr. Seow was talking, I said, there's the aftermath too that we have to be aware of and care for each other in those tender moments when everybody goes away because all the chopped egg sandwiches have been eaten, everybody's gone. There's this other place that we need support as we transition into this new place in the space where that loved one used to be. Thanks, Bill.
Thank you to all three of you. Deeply grateful. Lots and lots of accolades in chat. People have been really touched by your perspectives, the interweaving of conversation, and the very real and raw presence we bring in this topic. I'll close with just some last words about us who are hosting this. We exist in the Bow Valley. We train volunteers to be accompanying people in their journeys with an illness and in grief. We do presentations on navigating grief in the workplace, in personal life, for professionals, for the public. If you'd like to access these things, please reach out to us. And for all of us who are working in the not-profit sector, which is PCSBV, thank you for the gifts of time and energy, financial donations, everything that is contributing to allowing these stories to move forward. So we welcome you as potential volunteers here, as clients, as donors, and those of us who are working towards the possibility of building a hospice building in this particular area of the world to keep doing our work. So thank you for the inspiration of the three of you. Dr. Mannix, sleep well, rest well this evening. And Dr. Seow, won't even be long for you. You're heading towards an afternoon coffee break in your part of the world. And Brian, what a gift to have you here in the Valley with us. Thank you for you as a resource. We will see you down the road, all of you, perhaps in some way. I look forward to how our paths might intersect. I wish you all well.
Here.
Good night.
Thank you.
Goodbye.